Module 2 is about growth and development. This first chapter, chapter 7, is just the basics of growth and development. So general principles of growth and development. So growth and development are both interrelated and interdependent processes, meaning that we need one to have the other. So for example, a person can't walk until their legs are longer and their muscles are stronger. So growth-wise, they have to get taller, and then development is the actual ability to walk. It is highly individualized for each person. So although we are going to talk about time frames for developmental milestones and things like that, it is different for everyone. So just something to keep in mind. The principles of growth and development can be also influenced by other factors. So things like, what is the environment that they grew up in? What are their genetics? What kind of nutrition is available to them to allow them to grow? So growth and development follows some orderly patterns. So one of them is cephalocaudal, which means that the development starts at the head and moves downward. So an example of this is that a child can control his or her head or neck before they can purposely control their arms or legs. So they may be able to look towards a sound before they can reach for something. Another principle is proximodistal development. So this is where development that starts in the center of the body and moves to the periphery of the body. So an example of that is similar to the last one, but movement and control of the trunk section of the body occurs before control of the arms. So for example, a baby may be able to roll over again before they can purposely pick something up. And then differentiation, that means progression from simple tasks to more complex tasks when we're talking about development. So an example of that is a baby usually learns to crawl before learning to walk. So some examples of developmental milestones are shown in this chart, which is from your book. These are just some examples of course, some of them, and this only goes up to 5 years of age. I do suggest that you look in your book starting at page 147. It does list this in more detail. It's just way too much information to put on a PowerPoint presentation. So look in your F.A. Davis book and in your ATI book for more developmental milestones. You do need to know the difference between fine motor and gross motor. So you can see on here they are in 2 separate columns. But some examples of what's on this page. So by the time a baby is 3 months old, they should have the fine motor developmental milestone that they can follow an object to midline. So that's basically if you're holding a toy in front of them, maybe to the side of their head, and you're sort of moving it towards the midline of their body, like right in front of their face, they should be following that with their eyes. Or by the time they're 7 or 8 months, they should be able to sit unsupported. So again, these time frames are unique for everyone. So say a baby can't sit unsupported by 8 months of age, it doesn't necessarily mean that something is wrong with that baby. It may just be something that we need to keep monitoring to make sure that they do eventually meet it sometime soon. If they didn't, it could mean that something is wrong. But again, these are just time frames that are average for most children. So now we're going to talk a little bit more about growth. There's a lot of info on this slide. You don't need to worry about memorizing how much weight a toddler or a preschool or a school age or adolescent child gains every year, or how much they grow in height. What we do need to focus on this slide is more of the infants, facts, and then these safety considerations that are on the right side of their screen. We will talk about a lot of these as we go on. This is sort of like a nice place where it summarizes it. So you do need to know these safety considerations as well. But for infants, what we need to know is that their birth weight doubles by about 6 months of age. So say the baby was born at 7 pounds. By the time they're 6 months of age, they should be about 14 pounds. Also, by the time they're 1 year, their birth weight should triple. So again, that same baby that was born at 7 pounds should now be about 21 pounds by the time they're 1 year of age. You don't need to memorize the height for babies. Another thing to know is that babies usually start erupting their baby teeth around 6 months of age. They usually have around 6 to 8 deciduous teeth by 1 year of age. That just means baby teeth. And then by 3 years of age, they usually have all 20 of their baby teeth. Growth charts. So there will be hotspot questions on your exam regarding growth charts. So you do need to know how to use them or plot on them. So the one shown on your screen is an example of one for girls. You can use it for anyone from 0 to 36 months old. It has on both your left and your right hand sides length and weight. And then on the tops and the bottoms, it has the ages and months. It's kind of hard to show on a recorded PowerPoint exactly what to do on here. I will show you how to do this in class. But basically, you will be given a specific length, a specific weight, and then a specific age. And you're basically just matching up those ages and lengths and then ages and weights and plotting them on this graph. So say we give you an example of a 6-month-old baby girl that is about, 65 centimeters long. So basically you're going to either start at the top or the bottom and find the 6 months old, so just where the 6 is, and you're going to follow that line down until you get to 65 centimeters, which is most easily seen on the left-hand side of your screen there. And basically when you line that up, on this particular growth chart, that baby is going to be in about the 50th percentile for length. So what the 50th percentile means is that it's an extremely average baby for their length or height. So basically if you had 100 babies, all from shortest baby to tallest baby, this baby would be right in the middle, number 50. Same thing for weight. You just kind of have to move to more of the bottom part of the chart. If we gave you the same baby that's 6 months old and their weight is, say, about 7.2 kilograms, same thing for this baby. If you trace it up on this one, it's easier to go from the bottom, find the 6, up to about 7.2 kilograms. Again, that would be about the 50th percentile mark. You will have a little bit of leeway on your exam, just because it is sort of hard to read. You will be able to zoom on the exam. If you had a baby that fell in, say, the 5th percentile for weight, for example, that would mean that the baby is very skinny for age. So again, for example, if you had 100 babies from the skinniest baby up to the heaviest baby, and this one's the 5th percentile, that means it would be the 5th skinniest baby. So we keep track of these percentiles to see, is a baby or a toddler or an older child staying about on their percentile line. So if you had a baby that was born at the 50th percentile, like the first example I gave you, we would want them throughout this entire growth chart, so from 0 to 36 months, stay somewhere near that 50th percentile line. They don't have to stay exactly on it, but really what we don't want to see is them all of a sudden dropping off and being like 5th percentile, or it could be an issue for an older child, not so much a baby, but if they go up to, say, the 100th percentile and now they're very, very heavy. So again, it's not necessarily bad if a baby or a child is like 5th percentile and say they're short or small, or it might not be bad if they are the 95th percentile where they're really tall, or maybe they're a little bit heavy. It doesn't necessarily mean that anything is wrong with them. It's just that we want them to stay near their percentile that they started at. There are exceptions to this, of course. If a baby is born underweight, if they're born premature, they may be not even on this growth chart. So they may be 0 percentile, below 0 percentile. So in that instance, we do, of course, want them to jump up to a higher percentile because they were born small or premature. So there are exceptions. Primitive reflexes are reflexes that babies are born with, and they're reflexes, so they're basically movements or maneuvers that babies do reflexively, but not purposefully. So the first one on here is the Moro reflex. It's also called the startle reflex. So this one's pictured in the bottom right-hand corner. This one, you can elicit this reflex by gently lowering the baby's head, and sometimes also loud sounds will startle the baby. But when this happens, the baby makes this C shape with their hands, and they have their arms in the air, and they look scared, and they may cry. This reflex usually disappears around 6 months of age. The rooting reflex isn't pictured here, but it is where if you take, say, a pacifier and rub it on the baby's cheek, the baby will instinctively open their mouth and move towards the pacifier. The sucking reflex, we all know what that is, but this is the reflex of sucking, so it's not purposeful. So basically, if you stick something in the baby's mouth, like a pacifier or a bottle, the baby will instinctively start sucking. This disappears around 10 to 12 months of age. Of course, babies can still breastfeed after that. Again, it just becomes a purposeful movement at that time. The palmar grasp and the plantar grasp reflex are very similar. The palmar one is just with the hand. It's pictured on the top right. So when you put, say, your finger or something on the baby's palm, the baby reflexively grasps your finger. Same thing with their toes for the plantar reflex. If you put them right at the base of their toes, sort of on the ball of their foot, they will attempt to sort of grab your finger with their toes. The palmar disappears around about 5 months and the plantar around 8 months. The tonic neck or the fencing position reflex is one of the more confusing ones, but it's the one pictured on the bottom left. The fencing reflex, the name there makes sort of more sense, where it looks like the baby's fencing with swords. But basically, when you turn the baby's head to one side, in this picture, turning it to the right, then the baby's right arm extends out and their left arm flexes and their left leg flexes. This disappears around 6 months of age. The Babinski reflex, you may have heard of that one before, possibly in adult health. This one is where you draw basically an upside down J, or you can think of it as a candy cane on the baby's foot, starting like on the ball of their foot, and then sort of like the long part of the candy cane goes down their foot. When you draw that on there, it makes their toes fan out. This disappears around 12 months of age. The last one on here is the stepping or dancing reflex. It's not pictured, but when you are holding a baby, say underneath their armpits, they appear to start taking steps, like either in midair or if you have them, resting on a table, they appear to be stepping. This disappears around 3 to 4 months of age. We will show you these in lab if we haven't already, as best as we can with a baby doll. There are questions that you need to know about when they would about disappear. So if one of these primitive reflexes persists for longer than what we would expect it to, so say the Moro reflex is still around at 12 months of age, what this could mean is that there could be some sort of neurological problem. So now we're going to start talking about some developmental theorists. So the first one is Piaget, and he talked about psycho-intellectual development in children. So you may have learned about him before in some of your introductory psychology classes, but basically he theorized that development is a sequential process that's very orderly, and it moves from stages that are more simple to more complex. The child's experience with their environment does affect this, and it encourages growth and maturation and development. There can be overlap between the child's age and the stage of development, and each stage doesn't necessarily start and end at the exact same age for each child. So the first stage of Piaget's theory is the sensory motor stage, which is from birth to 2 years of age. So this is where the child is learning through those reflex actions that we talked about, and they start to understand that they are separate from the environment and separate from others. So researchers have shown that babies basically think when they are born that they are the same being as their mother. But by the end of this stage, by the time they are 2 years old, they of course realize that they are separate from their environment and separate from their mother. The most important thing about this stage, though, is object permanence. So this is where the child knows that an object exists even when it cannot be seen or heard. So this is when we think about playing peekaboo with a baby. So say if you're playing peekaboo with a young baby, and you hide behind a blanket, and then you say peekaboo and you reappear, then you hide behind the blanket again. When you're behind that blanket of a very young baby, the baby doesn't realize that you're still there, like they think that you're gone. So that's why sometimes it may upset babies, or they think that it's just hysterical when you reveal yourself and you're still there. So basically, by the time they're 2 years of age, they do realize that you, or whatever it is, still exists even if they can't see it or hear it. The next stage is pre-operational from 2 to 7 years. So this is where kids start to use language, although it's not fully developed at this time. So if we are doing something like explaining something to a young child that's, say, 3 years old, we can't just tell them with our words because they may not understand. This is where we'll have to use something like medical play, which we'll talk more about. They're also very egocentric, and they can't take the views of others. So meaning like they can't put themselves in other people's shoes. So this is sometimes where little kids may not know that maybe they're being mean or rude because they can't picture themselves in somebody else's shoes. They also start to use symbols to represent objects. So for example, if they're playing, say they pick up like a book and they pretend that that is a phone. It could also mean that they can understand a stop sign, even if they can't read the word stop on it. They recognize that symbol means stop. And the stage, these children are more oriented to the present. They can't conceptualize time very well, especially at the beginning of this stage. So if you say something like, well, we're going on vacation in 5 days, that may not make any sense to them. So you may have to say something different, like after we go to sleep 5 times, then we're going to go on vacation. Also, a lot of fantasy thinking during this time period, which goes along with fantasy play that a lot of children are doing in this stage as well. Next one is concrete operational, ages 7 to 11. So this is sort of a turning point in their cognitive development. So they're showing an increase in thinking and logical operation skills. So basically when they're in this stage, they can start to use operations or rules, but they can only apply these rules or operations to physical objects. Basically what that means is that they can't yet think abstractly or hypothetically. The last stage is formal operational, 11 years to adulthood. So basically their development cognitively is coming into its final form. They can now move past thinking only about physical or concrete objects, and now they are capable of thinking abstractly or of thinking hypothetically. So basically, they're more able to think critically at this time. The next theorist is Freud, and he had a theory on psychosexual development. So basically, this theory proposes that sexual energy is stronger in certain parts of the body at specific ages, and sexual feelings are present in different forms depending on how old the child is. Fixation of development can occur at specific stages if needs are not met or if conflicts aren't resolved. So Freud had 5 stages of psychosocial development. So remember, this is just a theory. It's a little weird, so take it with a grain of salt. So the first stage is the oral stage, which is during infancy from birth to 1 year. So during this stage, Freud said that infants are comforted through the mouth. This stage sort of makes sense. So children at this stage are preoccupied with activities associated with the mouth. So things like eating, chewing, sucking. So basically he was saying that a baby's sexual urges are gratified when they do these certain oral behaviors like sucking or chewing or eating. He said that if children do not have their oral needs met at this time, they could become thumb suckers or nail biters as time goes on. In adulthood, they could become smokers or compulsive eaters. The next stage, the toddler stage from ages 1 to 3, is called the anal stage. So this is where Freud said that children are preoccupied with the ability to eliminate, so they derive gratification from controlling their bodily functions. So basically, during this time period, they are usually potty training. So this sort of makes sense. So during this time, it's sort of like they are getting, I guess you could say, pleasure from learning how to be potty trained. During the preschool years, ages 3 to 6, this is called the phallic stage. So this is where children become preoccupied with their genitals. So they could be curious about things like childbirth or anatomic differences between different sexes. He also said that girls experience penis envy and boys suffer from castration anxiety. And they also, at this time, develop incestuous desire for the caregiver of the opposite gender. So you probably heard about the Oedipal complex before, where a boy is attached to his mother sexually. Or on the other end of the spectrum, the Electra complex is the attachment of a girl to her father. School age years from 6 to 12 is called the latency stage. So during this time period, Freud said that sexual desires are sort of submerged at this time. The kids are focusing more on their friendships and relationships with people that are the same gender as them. And then the last stage is the adolescent stage, 12 to 18 years of age, called the genital stage. So this is where a child may be struggling with sexuality. Their sexual desires return at this time due to fluctuating hormones and puberty. They may have changing social relationships, and they need to learn to basically manage their sexuality in socially acceptable ways. The next theorist is Erik Erikson. He had a theory of psychosocial development. So basically, in this theory, it consists of 8 different stages that addresses development over the lifespan. It does go into adulthood as well, although we're not going to talk about those stages. Each stage has a crisis that exists. And basically, the person has to have healthy development during this crisis and sort of like move on from it. So the person must master these crises to grow and progress to the next stage of development. So an individual either meets the healthy needs or does not, and this could influence their social relationships. So Erikson also had 5 stages with the same sort of time frames as Freud, but again, he's talking about psychosocial development. So the first stage in the infancy age range of birth to 1 year, it's called trust versus mistrust. So this is where an infant requires that basic needs are met. So they require food, they require clothing, touch, comfort, stay warm, things like that. If these needs are not met, then the infant will develop a mistrust of others. Also, sort of a related thing during this time is play. So play is usually considered a psychosocial activity, but during this stage, it's referred to as solitary play. So this is where a baby is basically, if they're playing with something, they're just playing with it alone. So they don't necessarily interact with other babies or children that may be near them at that time. The next stage in the toddler years is autonomy versus shame and doubt. So this is where the child is becoming more independent. They're learning to control their bodily functions, like being potty trained. They start to do other things like maybe try to get dressed by themselves. Basically, they want to have some control over their lives, and they need to be allowed to have some autonomy. So if they are criticized by their caregivers for showing independence, or they're not allowed to be autonomous in these safe ways that we can allow toddlers to be, then they basically can form a crisis at this time and then have shame and doubt about themselves that they can't do things. Play during this stage is called parallel play. So sort of similar to solitary play in infants, but in this stage, they may be playing near other toddlers, but not necessarily with them. So they may be doing very similar things, but say if they're playing with like dolls or action figures, they're not playing with them together. The next stage is preschool, which is initiative versus guilt. So this is where the preschool child is exposed to new people and new activities, possibly through things like going to actual preschool. So they're learning about their environment through playing with others at this time. It's known as associative play, where they do start to play with other children. They're learning new responsibilities and developing a conscience at this time. So basically, they're learning right from wrong. The next stage is industry versus inferiority in school-age children. So they start to take pride in their accomplishments, especially of things that they may be doing at school or with sports. They might enjoy working with groups and starting to make more friends at this time. They also usually or like to follow rules and order, especially going along with, again, school. So they're developing at this time a sense of industry, which gives them purpose and confidence in themselves. If the child's unable to be successful, it can result in a sense of inferiority. So again, we can think about this like thinking about a child going to school. So say the child's doing very poorly in school, they can think of themselves as inferior. Play during this stage is known as cooperative play. The last stage is identity versus role confusion in adolescents. So this is where children of this age are preoccupied with their appearance and what other people think of them. They're working to establishing their own identity, like who they want to be when they grow up, things like that. They're trying out new roles, trying to see what best fits for them. If they're unable to provide a meaningful definition of who they are, then they're at risk for role confusion in one or more roles throughout their life. The last theorist is Kohlberg. He had a theory of social moral development where he theorized that kids acquire moral reasoning in a specific developmental sequence. Basically, when he theorized that when they are born, humans are void of any morals or ethics, And basically, moral development occurs through the environmental interaction around all of us. Kohlberg just had three different stages for his social moral development theory. The first one is the pre-conventional level, which is from 2 to 7 years of age. So this is where the child is following rules that are set by those in authority, meaning like their caregivers or school teachers, things like that. And they're just going to automatically adjust their behavior according to what is good or bad and what is right or wrong. From 7 to 12, this is called the conventional level. So this is where the child is seeking conformity and loyalty. They're still following rules, but they may just be sort of going along with their parents or their friends' sort of morals or ethics. The last stage is the autonomous level, 12 years and older. So this is where a child starts to form their own value system that is independent of their friends and authority figures. So basically, they're sort of coming into their own, and they may have their own morals and their own ethics that may be different than, say, their parents or their friends. So Albert Bandura also had a social learning theory. So his social learning theory basically demonstrated the power of observation or modeling on children's development. So basically what he did was he had this blow up clown thing called a Bobo doll. And basically he put the Bobo doll in a room with adults where children could observe through like a one-way mirror. Basically, he told the adults to do violent acts on the Bobo doll. So like punch it and things like that, call it names. So basically, the children watched adults do this. Then he put the children in that room with the Bobo doll, and they basically mimicked the adults, especially when the adults were praised for their behavior or were where they weren't basically punished for it at all. So basically, they saw adults being violent towards this doll, hitting it, cursing at it, whatever, and they were praised and not punished for it. Therefore, the children went in and then did the exact same things. So basically, he said that through observing the actions of others, children can develop new skills, whether good or bad, and acquire new information. Chapter 8 is about the growth and development of newborns and infants. So this first part is about newborn transition and transitioning to extrauterine life, which overlaps with OB's content. However, you won't learn about these things in OB until the end of the semester in that class. So we just go over it very briefly here because it does come into play with a couple of things. So basically, newborn transition means when a baby is transitioning from being in the womb to now being in the outside world. So basically, when the baby is first born, there's a couple things that we need to quickly do. So the first thing is checking for a patent airway. So that basically means like listening to see, is the baby crying? If they're not crying, we could be suctioning their nose, suctioning their mouth, things like that. Now, a lot of these steps here, it says 1, 2, 3, 4, but they all kind of overlap and you're kind of doing them simultaneously. But number 2 is immediately drying the infant and applying warm blankets. So basically when the baby is born, it's very wet. So we want to dry the baby off so that it doesn't become cold because it can very quickly become cold, which we'll talk a little bit more about. So drying them off with warm blankets and wrapping them with warm blankets. Or even better is number 3, placing them on the mother's chest, and then you can lay a warm blanket over the top of them. But placing them on the mother's chest is going to, 1, help them keep warm, and 2, help with bonding with the mother. The very last thing is applying a hat, and again, just to keep the baby warm. So how does a baby start breathing once it is born? So when the baby is in the womb, it's getting oxygen via the umbilical cord and via the placenta. So once the baby is born and the umbilical cord is clamped, at that very moment that the baby is getting no more oxygen from the umbilical cord and therefore needs to start breathing. So when the umbilical cord is clamped and when a couple of other things happen as well, it basically, we get a lot of stimuli from both internal and external things that are going to cause the baby to take its first breath. So some of the internal stimuli that happens when the umbilical cord is clamped. So basically, right when they clamp the umbilical cord, in the baby's blood, if you were to do an arterial blood gas at that very moment, you would see that their PO2 is dropping, their pH is dropping, and their PCO2 is increasing. So these chemical changes are basically going to activate certain receptors that are going to send a message to the brain for the baby to take their first breath. There's also external stimuli. So these are things like being touched by someone for the first time. So like the obstetrician touching the baby, helping pull it out. Other stimuli such as sound. The baby can hear things in the womb, but now they're out and it's going to be very loud. Light, and cold air. So all of these external stimulus are going to also activate some receptors that's going to stimulate the respiratory center in the brain to make the infant take their first breath. Now, all these things are basically happening simultaneously and hopefully very quickly so that they immediately start to take their first breath or basically immediately start to cry. The first breath that the baby takes begins to clear the amniotic fluid out of the lungs. So basically the lungs are full of amniotic fluid when the baby is in the womb. So now basically by taking their first breath and crying, this starts to clear the amniotic fluid. So some other things that a nurse should be aware of during respiratory transition of an infant. We already talked about assessing the nose or the airway for patency. So they could be clogged with basically snot or amniotic fluid or even meconium. So we could need to suction that. We also want to basically do a respiratory assessment. So we are going to look at the chest. Is the chest wall rising symmetrically? If it wasn't, it could be a sign of pneumothorax. The respiratory pattern in infants is very irregular. So basically what that means is that, for example, for a period of time, say 10 seconds, the baby could be breathing very quickly. So maybe during that 10 seconds, they're essentially breathing at 70 breaths per minute. Then they might slow down for the next, say 20 seconds to 40 breaths per minute. Then they might speed up again to 60 breaths per minute. Then they might slow down to 20 breaths per minute. It's basically just very irregular and sporadic. It's also diaphragmatic, meaning that you may see their belly moving as much as their chest. The average respiratory rate at birth is around 30 to 60 breaths per minute. We do want to count for a full minute, and that is because of that irregular pattern. So say you only assess for those first 15 seconds where the baby was breathing basically 70 breaths per minute, then you may have a falsely high or low respiratory rate because you only did it for a short period of time. The respiratory rate does decrease with age, so we'll talk about that more in lab if you haven't already had lab. Another thing we want to look for is acrocyanosis, so which is pictured here, which this is a bluish tint to the hands and feet. It is normal in a term infant for the first 24 to 48 hours. So this is something that you can educate parents about if they don't already know about it. But this doesn't mean that the baby has a low oxygen saturation. If you were worried about it, you could always pop one on and see that it is normal or what is expected for how old they are. In dark-skinned infants, this could be harder to see, and of course you can assess for true cyanosis through their mucous membranes. Thermoregulatory system transition and assessment. So a normal neonatal temperature is around 36.5 to 37 degrees Celsius if we're doing the axillary method, and could be a little bit higher for core temps like rectal temps up to 37.5. Basically, we just usually don't want a neonate to be under 36.5. So if they're under 36.5, we usually want to take measures to start warming them up. We're also usually going to do axillary temperatures because they are less invasive. There are other methods as well, of course, like temporal, but axillary is probably going to be the most common. Rectal is done more frequently in the ER, or if you need to verify a very high or a very low temperature that you get by the axillary method. Neonates do have a higher metabolic rate. So basically, we do want to make sure that they're in a neutral thermal environment so that they're minimizing metabolic and oxygen needs. So basically what that means is we want to make sure that we keep them warm. We don't want them to get cold. They also do not shiver. So this is for neonates or newborns. So older infants can shiver, but newborns do not shiver. So basically they don't have that method of warming themselves up. So if you do see a newborn that appears to be shivering, it's probably not shivering and it's probably seizing. Gestational age term infants, so basically full-term infants, have stores of brown fat that's used and burned for heat metabolism. So basically brown fat is a special kind of fat that the body can specifically use just for heat metabolism. So it's located in areas like in the groin, in the scapular area. So if the baby is preterm, they're going to have 0 to very low amounts of brown fat. However, we don't want them to rely on this brown fat to stay warm. If they are burning through or metabolizing that brown fat too quickly, it can cause things like metabolic acidosis. So we do want to keep them warm. So now we're just going to talk about a few nursing procedures that are specific to newborns and infants. So one thing that you could be required to do as a nurse is assisting with circumcisions. So of course the pediatrician or neonatologist is going to perform the circumcision, but you may be helping basically hold the baby down. You can give them a pacifier and sucrose. So sucrose is what's pictured in this top picture. It's basically sugar water, and it has been shown through research to actually provide pain relief to infants. So it can come in one of these little cups that you can basically dunk the pacifier into, or these little bullets that are like the saline bullets, but they contain sucrose that you can carefully squirt into the baby's mouth with the pacifier. Some doctors may order acetaminophen to pre-medicate the baby with for pain. So that could be a possibility of something that you would administer to the child. And then after the circumcision, the main thing that we need to do is assess the site frequently and watch for bleeding. So basically, we're just going to put a diaper on the baby after the circumcision and do a couple other things that I'll talk about in a second for discharge care. But we really want to make sure it's not bleeding at all. So checking very often the diaper area to make sure that there's no blood in the diaper. Discharge care for the circumcised infant. So things that we're going to tell the parents to do and things that we're going to do while the baby is still there in the hospital. So we want to make sure that the diaper isn't on too tight. Now, not so loose that poop and pee come out or it falls off. But we just don't want it to be too tight, pressed up against the circumcised area. Some doctors are going to apply petroleum gauze, which is basically just gauze that has petroleum like impregnated into it. They also use that on chest tubes if you've seen that with adults. So if that petroleum gauze is on there, it's basically, it looks like yellow gauze. It's going to stay on there until it falls off, so we're not going to remove it. Other times they may have you just apply petroleum or Vaseline to the area. You could be covering that with regular gauze, but basically just a whole lot of Vaseline or petroleum to keep the area moist. I also want to tell parents to make sure that they're changing the diaper frequently, especially if they have pooped, to make sure that no bacteria or anything gets on the circumcision site. If we're taking care of an uncircumcised male, there's nothing special that we need to do to clean the area. So we'll talk about this a little bit more in another module, but with most infants, you're not going to be able to retract the foreskin, which is normal, so we don't need to try to do that. So basically for cleaning, we're just going to clean like any other body part. Medication administration for newborns and infants. So obviously newborns and infants can't swallow pills. So the majority of the oral medications that we're going to be giving to them are going to be oral liquid medications. Of course, we can give them, IV or IM or sub-Q injections, but those things are all going to be basically the same as with adults. But when we're giving a baby an oral liquid medication, there's just a couple things to be aware of. So as you can see in this picture, this person is basically inserting the syringe sort of into the baby's cheek area. So we want to make sure when we are pressing the liquid out of the oral syringe that we're not shooting it violently into the back of their throat to cause them to choke. You can also sort of sneak the syringe around a pacifier so that when they're sucking on the pacifier, they are basically drinking the medication at the same time. You can mix it with milk or formula in most instances. You just need to be careful because what if the baby doesn't drink the entire amount of formula or breast milk that you mixed it with? So if you do mix it with a medication or with some sort of breast milk or formula, make sure that it's a small amount that you're sure that the baby is going to take the full amount of. So not mixing, like 2 mils of a medication into an 8-ounce bottle of milk, because what if they don't drink all of that? Then you have no idea how much medication they got. Another procedure that basically all newborns are going to receive is the newborn screen. So what the newborn screen is a screening tool that screens for metabolic disorders that can occur usually when there's the absence or abnormality of some sort of enzyme. So the absence or abnormality of this enzyme can lead to an accumulation of specific metabolites that basically are toxic to the infant. So basically this is looking for certain disorders. Some examples are things that you probably never heard of and don't even have real names, but other more common things are things like sickle cell or cystic fibrosis and things like that. So this is basically performed on every newborn in every state. However, each state has a separate lab. So they may be testing for different abnormalities in each state, although they're very similar in each state. So there is 2 separate screenings. So the first screening is performed after 24 hours of life, so in between 24 and 48 hours of life. So once the baby hits 24 hours old, the nurse can collect the first newborn screen. The second screen is usually around 5 to 10 days of life in Arizona. So unless this baby is in like the NICU or PICU, it's usually done at their pediatrician's office. The first one, however, it's usually done in the hospital unless they have a home birth. So to test for this, we use capillary blood drawn from the heel. So basically, you have a little lancet that's similar to a lancet that you would use to check someone's glucose, and you're going to poke it in the heel area that's marked on this diagram. So basically, not the bottom of the heel, but sort of like the side of the heel, if that makes sense. And basically, you're going to drop blood from their heel onto this newborn screening card, which is this special sort of paper. And there's 5 round dots that you fill with blood. You fill out a lot of information on this newborn screen paper, and it's sent off to the state lab where they do the analysis of that. One of the disorders that the newborn screens for is phenylketonuria. It's also called PKU for short. And this is an inherited error in metabolism. It's a little confusing because they decided to name both the enzyme and the amino acid phenylalanine. But basically what happens is that there is a deficiency of the enzyme phenylalanine, and as a result, it doesn't break down the amino acid or protein phenylalanine, and that leads to toxic amounts of it in the body. So a baby with phenylketonuria could have symptoms such as developmental delays as time goes on, poor feeding, poor growth. They could be irritable, fussy, have a rash, have seizures, have a particular body odor, and vomiting. They can also have light skin, blonde hair, and blue eyes, and this is because when phenylalanine is usually broken down, one of its products is used to actually make melanin. So this disorder is tested for in all 50 states. So in every state on their newborn screen, it is tested for. This is one of the reasons why there is 2 newborn screens. So an infant needs to be on feedings for 3 full days so that the enzyme that converts phenylalanine will be secreted. So basically, we're usually testing this at about 24 hours of life. So if a baby is especially breastfed, they may not have gotten very much milk at all before 24 hours. So they could have a false negative if we only did 1 test. So this is why there is a second test. If a baby ends up having phenylketonuria, the treatment for it is basically a very, very low protein diet. So low phenylalanine, low protein diet. They must follow this for, unfortunately, the rest of their life. How much protein they can have is going to vary from person to person. But what this means for specifically an infant is that they're going to not be able to breastfeed, and they're going to have to drink a special prescription formula that is low phenylalanine and low protein. But as time goes on, when they start to eat solid food, they can't have any high protein foods like meat, eggs, and things like that. Galactosemia is another disorder that is tested for on the newborn screen. It's also an inborn error of metabolism that consists of an enzyme deficiency. So it's an enzyme deficiency that prevents the breakdown of galactose to glucose. This one's also tested for in all 50 states. If it's not treated or diagnosed, it can lead to things like brain damage, kidney damage, failure to thrive, mental retardation, can have loose stools and be fussy, can also cause things like cataracts in the eyes. Basically, this one, the baby and the person, as they grow into an adult, cannot drink milk-based products. So this baby is going to need a soy-based formula. Basically, they can't have anything that has galactose in it. Another disorder common in infancy is hyperbilirubinemia. This one isn't tested for on the newborn screen, but is common in newborns. So basically, you probably already know that bilirubin is a pigment that's released from the breakdown of hemoglobin, can make the skin and the sclera of the eyes and the oral mucous membranes appear yellow or jaundice. So hyperbilirubinemia is an excessive amount of bilirubin in the blood. The specific number, laboratory value, the common one that's an indication for phototherapy is around 15 milligrams per deciliter. It is going to vary based on how old the baby is, what's their gestational age, and how much they weigh. But 15 is an average number. So that's going to indicate that the baby needs phototherapy, which basically means if anyone has seen the baby under the lights before. So sometimes the lights have sort of a blue hint to them, but it's basically UV light that helps break down the bilirubin through the skin. So the baby can't necessarily wear clothes at this time because we want all of their skin to get this light therapy. Their bilirubin level usually peaks about 3 to 7 days at 3 to 7 days of life. So basically, once they hit day 3 of life, their bilirubin level can start going up. So this means that most of these babies, unless they were a C-section, are already at home, but they may be following up with a pediatrician in this time frame. If hyperbilirubinemia is very severe and untreated, it can lead to what's called kernicterus, which is basically brain damage. So it's a life-threatening buildup of bilirubin in the brain and the spinal cord. So risk factors for hyperbilirubinemia include a mother that has diabetes, ABO incompatibility, and RH incompatibility. So that's when the mother and baby have different blood types. When the mother has type O blood and the baby has type A or B, basically an immune system reaction occurs and it causes excessive breakdown of RBCs. RH incompatibility is similar. When the mother is RH negative and the baby is RH positive, the mother produces antibodies against the baby's blood, and then again, excessive breakdown of RBCs, which can lead to more bilirubin. Other things like prematurity, the baby will have a premature liver as well. Bilirubin is broken down or processed in the liver. So if the liver is immature, then it won't be able to do its job properly. Delayed feeding. So the way that the baby is going to excrete this excessive bilirubin is through their urine and stool. So if they're not able to eat, they may still, of course, be urinating, especially if they're on IV fluids for whatever reason. But it does pass through the meconium. So if they're not eating, they're not pooping. Any sort of birth trauma that can cause a lot of bruising. So do they have a cephalohematoma, or did they just have any bruising in general from some sort of traumatic birth that can cause an increase in bilirubin? Again, liver immaturity, any stress to the neonate. So were they cold at birth? Did they suffer from asphyxia? Did they have low blood sugar? Did they use Pitocin in labor? Some ethnicities are more prone to hyperbilirubinemia, a sibling history of jaundice, and breastfeeding. So of course, we're already aware that we are going to measure a baby's weight and their height or length at birth. The average birth weight in the United States is about 7.5 pounds. And the average length is around 19 to 20 inches. There are different categories for weight that you may see. We're not going to have any test questions about them. You may in OB, but you may see things like average for gestational age, small for gestational age, large for gestational age, low birth weight, very low birth weight, things like that. A new one, though, may be head circumference. It's also called OFC, which is occipital frontal circumference. So this is basically measuring the baby's head sort of through the middle of their forehead all the way around their head. So this is just another statistic that we're measuring, usually up to age 2 or 3, depending on the provider and how long they want to do it for. But basically seeing, is their head growing appropriately? When babies are born, their head and chest circumference are usually pretty close to the same number. The chest can sometimes be slightly smaller, like 1 to 2 centimeters less than the head. Normal vital signs for an infant. So temperature, as I said before, is basically going to be the same as an adult. So nothing new here. We just want to make sure that they don't get any colder than 36.5. Pulse. So these are going to vary depending on what text you look at. We're not going to ever give you any questions that are just right on the border where you're not going to be able to decide if it's normal or not. But normal pulse is going to be anywhere from about 120 to 160. We can count the apical pulse rate for 1 full minute. Of course, the rate is going to increase if the baby's crying. So not a great time to check the pulse rate during crying. And then it could be a little bit lower if they are in a deep sleep. Respirations, we already said, are about 30 to 60 breaths per minute, and we do want to count for a full minute because they are very irregular. Just like with pulse, the rate is going to increase when they're crying and decrease when they're sleeping. So again, we want to try to do vital signs when an infant is sleeping if at all possible. They can have very short apneic episodes. We don't want them to be usually any longer than 20 seconds. If it's over 20 seconds, that's when it becomes a problem, which we'll talk more about later. And we do want to hold any oral feedings if the respiratory rate is truly greater than 60 breaths per minute. If they're breathing faster than that, it's just not safe for them to eat orally because of the risk of aspiration. So if it is sustained over a long period of time, they may need something like a feeding tube. Blood pressure is not a routine part of neonatal vital signs, with some exceptions. So like on a postpartum unit or at the pediatrician office, they're not going to take a blood pressure at all. But if the baby is hospitalized, say in the NICU or the PICU, or maybe even just on a regular floor, you are going to be doing a blood pressure. It is going to appear fairly low, with the systolic being around 50 to 75 and the diastolic being around 30 to 45. Nutrition-wise, of course, parents can choose whether they want to breastfeed or if they want to bottle feed a commercially prepared formula. We just need to educate them that if they are going to feed formula, they do need to use an actual commercially prepared formula and not a homemade recipe. Supplemental iron is usually not necessary for younger infants under 6 months, but according to your text, all infants 6 months and older should be taking iron supplementation. However, with my experience, it can depend on your provider. Iron can also be supplemented just by eating food. So if they're eating any lean red meats, spinach, broccoli, fortified cereals, beans and things like that, then they can get supplemental iron through that route instead of an actual supplement, which are honestly not very tasty. Another thing we want to educate parents about is not feeding cow's milk until they're at least 1 year of age. And this is, again, because of iron. So cow's milk is very low in iron naturally, and it's also low in fat, depending on which kind you get. But it's not nutritionally complete, and parents should wait until they are 1 year of age. Soy formula should also be reserved for infants who need it for a medical reason. So things like, do they have galactosemia? Do they have lactose intolerance? Do they have a true allergy to cow's milk? So soy formula is not nutritionally complete. It's not the best option. So parents shouldn't be choosing that just because they don't want to use other types of formula. So an infant is usually ready for solid foods at around 6 months of age. Basically, we need to make sure that the baby is able to move food around in their mouth safely. We want to make sure that they can sit up in a high chair, they can hold their necks straight, and that when you do place something in their mouth, they don't instinctively push it back out. Many people in the United States do give pureed food earlier than 6 months of age. Again, we just want to make sure that the baby can meet those requirements of being able to sit up straight, hold their neck straight, and things like that. When we are feeding them, we do want to make sure that we are actively paying attention, placing food on a spoon, not putting it in a bottle. Um, the first type of food to give a baby is usually recommended to be baby rice cereal. Um, One of the reasons why is because it has a low allergy risk. Around 8 months of age, you can start using strained fruits, vegetables, and strained meats. Self-feeding, so like a baby basically picking stuff up themselves. Again, they need to be able to sit up straight, hold their necks steady. They need to be able to have the pincer grasp to pick up food, which is usually around 9 months of age. We can wean infants from a bottle sometime around 1 year of age. Sometimes it's a little bit before, sometimes a little bit after, depending on the baby. We want to wean to a sippy cup, usually one that has handles with a snap-on lid. The nighttime bottle feeding or breastfeeding is usually the last feeding to be removed because a lot of times it helps the baby fall asleep. We want to make sure that we're giving babies foods that they aren't going to choke on. So usually that means giving them foods that are soft and not hard to chew, because depending on how old the baby is, they may have no teeth or very few teeth. So foods that result in a decreased risk for choking are things like cooked pasta, small pieces of soft cheese, cooked vegetables, small pieces of fruit, small pieces of toast. Grapes are okay, but we just need to make sure we cut them into little pieces because that is a high choking food. Making sure that we thoroughly cook all food and cut up all food into small pieces. Again, babies don't have very many teeth, if any at all, and they can't chew them up themselves, so we need to make them small. If we're feeding them any kind of fruit that has pits or seeds, make sure that we're removing that. And we can add liquid to some more solid foods, such as breast milk or formula, to make it more of a puree. Newborns sleep on average about 8 to 9 hours during the day and about 8 hours at night. So if you add that together, about 17-ish hours a day. They don't normally sleep through the night until they're around 3 months old. Their stomach basically has to be big enough to hold enough milk that they don't wake up hungry. For our test purposes, you don't need to memorize the different stages of sleep, but just know that they do progress through the REM and non-REM sleep as adults do. Around 6 months of age, the infant may begin to sleep 8 to 12 hours at night, so basically all through the night and maybe even longer than what their parents are sleeping. This is, again, highly variable from infant to infant. Others may sleep through the night very early, and while others may take even longer to sleep through the night. SIDS is sudden infant death syndrome, and it's the leading cause of death in babies from 1 month to 1 year of age, and it peaks between 2 and 4 months. So these are infant deaths that are from an unknown cause. So they are not from causes such as vomiting, choking on milk when they're drinking, abuse, any sort of infection, or anything like that. It does occur more often in the winter and in certain ethnicities. It can also be more common to infants of mothers who didn't have any prenatal care and who smoke. And we do want to give mothers and caregivers the Safe to Sleep, used to be called Back to Sleep, which takes measures to try to prevent SIDS from happening. So although SIDS happens from unknown causes, there are some safe sleep habits that we need to teach caregivers. So we always want to place babies to sleep on their backs when we put them down to sleep. So even if they do have the ability to roll over, we want to initially put them down on their back. We also don't want to cover their heads with anything. This seems fairly obvious, not covering their heads with a blanket. And we also don't want to over bundle them. We want to avoid letting the baby get too hot by over bundling them. So if the caregivers see the baby with flushed cheeks, actually sweating, if they're breathing quickly, it could be a sign that they're too hot and that they need to remove clothing. So we want to dress the baby lightly for sleep, basically sort of the same as we would want to sleep ourselves. We want to also make sure that parents are using a safety approved crib and that it has a firm mattress, so not a really soft, squishy mattress that the baby could suffocate in. We want to make sure that the crib is in an area that's smoke free if the parents do smoke. This is a little controversial, but we don't want to allow babies to sleep with adults on adult beds, chairs, sofas, anything like that because of the risk of suffocation. We also want to make sure that the baby's crib doesn't have any extra stuff in it that they don't need. So no stuffed animals, no pillows, no special wedges, no bumpers that go around the edge of the crib, no blankets even. You can tightly swaddle the baby or put them in a sleep sack, but we don't want to have anything that could enhance the risk of suffocation. Breastfeeding has also been shown to reduce the risk of SIDS, and even if the parents don't breastfeed, using a pacifier at bedtime has been shown to reduce the risk. We can also educate parents about signs of illness in the newborn and infant and when they should contact the pediatrician or even perhaps take them into the ER or urgent care or pediatrician's office. So they should be taught how to take a temperature. If it is a fever, then they may want to call the pediatrician, depending on how high it is. If the infant has any symptoms such as vomiting, and vomiting meaning throwing up good amounts of formula or breast milk. So not little spit ups, which are normal, but actual vomiting. Do they have a decrease in the number of wet diapers, which could be a sign of dehydration? Do they have a sunken fontanelle, which could be a sign of dehydration as well? Or a bulging fontanelle could be a sign of a neurological problem. Is the baby not wanting to eat? Do they have a circumcision and there's bleeding or foul odor or from their umbilical cord area? Do they seem like they're excessively tired or lethargic or have a decreased level of consciousness? Are they extremely irritable? Are their hands and feet blue or cold? And this is after the normal acrocyanosis period, but still during that period, their hands and feet should not be cool or cold. Do they have any sort of skin rash? Because those can be associated with certain communicable diseases. And also, do they have any drooling that's not associated with teething? If they do have this, they could be at risk for aspiration, and it could also be associated with a couple communicable diseases as well. We do want to teach the parents how to take a temperature in the newborn. The most popular way is to do an axillary temperature, and you can just use a normal oral thermometer for that. We can teach parents to do it in the same manner that we would do it. Let them know that they don't need to lubricate the thermometer in any way. Just hold it snugly under their armpit until it beeps. We do need to let them know that the axillary method could show a lower temperature than what the temperature of the baby actually is, could be up to 2 degrees lower than their actual core temperature. We do want them to not use rectal temps unless absolutely necessary, just because it is more difficult and invasive and there is a chance for injuring the baby. But if they do need to do one for whatever reason, educating them that they do need to lubricate the end with a water-soluble lubricant and then insert it no farther than about 1/2 inch. Some more safety measures that we can educate caregivers about: making sure that they make and keep their infants' pediatrician's appointments so that they can get checkups and vaccinations. You do not need to know the vaccinations at this time, but common checkup times are 2 months, 4 months, 6 months, 9 months, and 1 year. So not only do they get vaccinations at this time, but we do need to have weight checks to make sure that the baby is growing appropriately. We already talked about the safe to sleep positioning on their backs and all the safety things that go along with that in an earlier slide. We also want to prevent diaper rash. So making sure that parents know to check and change the diaper frequently and making sure that they know to wipe from front to back in girls. Make sure that they have doctors and police, fire, poison control numbers nearby if needed. Making sure that they know to use child-proof locks and safety gates. So locks on things like cabinets where cleaning supplies are kept or medications are kept, locks on windows and toilets, anything that a baby could get into, especially once they start to be mobile. Keep anyone that's sick away from the infant. Their immune system is not at its full capacity yet when a baby is born, so they can get sick easily. If they have any of those signs of the illness that I talked about previously, make sure that they call the physician, and call the physician if they have just any questions or worries about the infant's growth and development, if they think they're not meeting a milestone. We want to make sure that we keep the infant away from cigarette smoke, and of course keep firearms in a locked cabinet or safe. We don't want to leave babies home alone or in a car. And we want to make sure that we're paying attention to recalls of infant toys and equipment. Also want to make sure that they have fire and smoke alarms and carbon monoxide detectors with working batteries on every level of the home, and make sure that they take extra precautions against things like drowning if they have a pool, car seat safety, electrocution. They have the safety things that go into the electrical sockets, and safety around pets. Another topic that we need to educate caregivers about is child abuse considerations, specifically shaken baby syndrome. So with shaken baby syndrome, head trauma results from injuries that's caused by vigorous shaking of the baby. So the anatomy of the infant puts them at a higher risk for this type of injury rather than adults. Most victims are between 3 and 8 months of age. Research suggests that teenage fathers are more likely to cause shaken baby syndrome. So we want parents to make sure that they are aware when they're choosing people to watch their children. Common injuries from shaken baby syndrome are called contre-coup injuries, which means that they actually have an injury to the opposite side of the head, which you may think. This can result in things like detached retinas, which can lead to blindness, permanent brain damage, and death. Abduction prevention for infants. So if we're in the hospital, depending on what unit you're on, infants could be banded with an electronic tag to prevent abduction. One of these brands is called Hugs tags. So it's like a little band that goes around their ankle. So this makes an alarm sound if the infant is taken out of the specific unit or area that they're in. There's also a code pink, which this could be for an infant abduction. It could also be for any child that can't be found. So, for example, like a teenage child that may have ran away from the unit. So a code pink could be called overhead, and basically staff needs to be posted at each door and basically asking people where they're going, possibly even like checking bags and things like that. Depending on where you work, hospital staff that deal with pediatrics should have badges that identify them, that they can transport babies and other pediatric patients. So a lot of times in some hospitals, this badge may be pink, whereas other employees that don't work with pediatrics, they may have a different color badge. For at home, we can educate parents that when they are out shopping, to make sure that they don't turn their back on their infant, make sure that they are secured in the seat and buckled into the shopping cart. Also, when people are loading up, say, their groceries or other bags into their car, making sure that they put the infant into the car, into their car seat first before they start to load their groceries. We also want to make sure that they are educating anyone who's babysitting their child about abduction prevention as well. Warning signs of sexual abuse, physical abuse, and neglect in an infant. So signs of sexual abuse that you could see are things like bloody diapers. Do they have any pain or swelling, redness, or odd discharge in their genital or rectal area? More vague symptoms like difficulty eating or sleeping, excessive crying, withdrawing from caregivers, and then failure to thrive, which means that they aren't growing appropriately. Warning signs of physical abuse. Do they have repeated injuries that are in the shape of something? So like the shape of a hand, the shape of a belt buckle, the shape of a cigarette burn. Do they have injuries that are unlikely given the age or the ability of the child? So if a child can't walk, we would assume that they are not able to do things like run or climb up things yet, so they might not have injuries such as like a broken leg. Of course, accidents happen, but sometimes we may want to investigate more, ask more questions if they have certain injuries. Spiral fractures are sometimes indicative of abuse as well. Is there any inconsistency in stories or explanation of the injury that's given by different caregivers? Or is the explanation unreasonable or doesn't really make sense? Is the infant withdrawing or do they seem fearful of the caregiver or whoever brought them in? Infant neglect could be shown by the consistent failure of the caregiver to meet the child's needs. So are they not giving them proper clothing, proper food? Are they refusing to show affection? Are they not giving the baby medications or things that they may need for specific disorders? Or did they delay in calling for help or taking the infant to a doctor when it's sick? Chapter 9 is about toddlers and preschoolers' growth and development. And the first thing here is vital signs for both toddlers and preschoolers. As you can see, the heart rate and respiratory rates are slowly getting lower and lower, while the blood pressure is getting higher and higher with each age group. Again, just keep in mind that different texts are going to have different ranges. So even your F.A. Davis and ATI book are going to have slightly different ranges. So just something to keep in mind. The toddler age group is from ages 1 to 3. So motor development. So developmental milestones that toddlers should be able to reach or should be able to complete by the time they are 3 years old. They should be able to walk alone, run, walk on their tiptoe, start to build towers with blocks, kick balls, climb, turn doorknobs, wean from the bottle and use a sippy cup, and feed themselves with finger foods. Language skills. By the time they are about a year old, they should know 5 words. And by the time they're 18 months old, they should know about 50 words. And this progresses to speaking in small or short sentences. They also may point to objects if they don't know the name of it. And they recognize their own name and others' names. Cognitive-wise, they can find finding hidden objects. That goes along with object permanence that we talked about earlier. They can sort colors and shapes. Common to have those toys that have different colored shapes that they put in different holes to make sure that they fit. They start to use make-believe. They may start to scribble with a pencil or crayon, and you may start to see hand preference emerge. Socially and emotionally, this is where toddlers engage in parallel play, like we talked about before, where they may play with the same toys near other toddlers, but they may not necessarily be actively playing together. They do start to show affection during this time, so things like hugging and kissing, but they also, on the other end of the spectrum, throw tantrums. They become aware of themselves and they often imitate others. Preschooler growth and development. So this is ages 3 through 5. So under the motor development category, they can start to dress and undress themselves. They do still need assistance, but they can start doing that at about age 3. They can go up and down the stairs without assistance around age 3. They can start to draw simple shapes like squares, circles, triangles. They can start to use utensils, so like a fork and a spoon and an actual cup around age 3. They can start to use safety scissors around age 4. They start to draw people. They are stick figures. Later, they will draw them with bodies, but around age 4, stick figures. They can start to brush their own teeth and go to the toilet without any assistance around age 5. Language skills, they start to speak in progressively longer and longer sentences. They may start to tell stories and use the future sense. They can also comprehend rhyming, which we all know goes along with nursery rhymes. Cognitive skills, they can count to 10, but they may not have any concept of numbers. So while they may be able to go 1, 2, 3, 4, 5, etc., if you ask them how many pennies do you have in front of you, they wouldn't necessarily be able to count them. They can identify at least 4 colors, and they begin to understand some concept of time. They start to use a lot of imaginary play, be very creative, and they ask a lot of why questions. Social and emotional milestones, they start to be proud of their abilities and become more and more independent. They start playing with others that are around their same age. They can also be scared of things, so they start to believe in monsters. They start to notice differences in gender and race. And they also are worried about their body integrity, which is key for nursing. So this is things like they're worried about if they get a scrape, they're worried about losing all of their blood, things like that. We do want to avoid yes or no questions, and we want to give them options. So instead of saying, okay, can I put in your IV now? They're automatically going to say no. So instead, we should try to give them an option. You could say something like, do you want to take your medicine first, or do you want me to put in a new IV first? Then it gives them some sort of option and some sort of level of control, and it may help them be more cooperative. Now, it's not going to work every time, but it's worth a shot. Challenges with these age groups. So potty training usually begins around age 2 to 3 years, just depends on the child. We want them to be showing interest in it. So that means they may be asking to use a potty, maybe like mommy and daddy do, and they start to be unhappy with having a dirty diaper. They also need to have the physical ability to actually pull their pants up and down. When they're younger than 2, they usually don't have that ability to do so. And they also need to be able to vocalize when they have to go. So they have to have enough language skills to be able to say that they need to go potty. Separation anxiety also peaks in the toddler stage, so around 10 to 18 months. So this is where, for example, a caregiver is dropping off their child at daycare and the child just throws a huge fit and cries forever because they don't want to be separated from their caregiver. Also, everyone's probably heard of like the terrible 2s or terrible 3s. So a lot of tantrums, and it can be difficult to discipline. So the toddler or the preschooler might not yet understand what they did wrong. And they also have just so many emotions that they don't know what to do and they don't know how to control them, which can turn into a tantrum. They can also exhibit sibling rivalry, especially when someone in this age group has a new baby brother or sister. They could be jealous of the new attention that's going to the new baby. Nutrition. So toddlers and preschoolers eat frequently with mini snacks. So they may eat 3 meals a day, but then also a snack in between each of those meals. They might not want to sit down for meals because they're always on the go and running around and wanting to play. They can be at risk for anemia, and one of those reasons is because they can be picky eaters. So they may not want to eat things like broccoli. It's normal for them to play with food and make a mess because they're just learning how to feed themselves and use utensils. Dental caries, another word for cavities. So we want to make sure that they're not drinking too much juice or anything else that has a lot of sugar in it. And we want to wean them from the bottle if they have not already been weaned. They do need to start seeing a dentist. It does help them get used to it. And then brush and floss their teeth when appropriate. So once they have 2 teeth that are actually next to each other, then they can start flossing, or of course their parents can help them. Some safety information for toddler and preschooler age groups. So according to the CDC, unintentional injury is the #1 cause of death for all children in the United States. The top 5 leading causes of death in children ages 1 to 4 are also accidents, mostly, besides homicide. But things like drowning, car accidents, fires, burns, suffocations. The leading cause of injuries that are not fatal are things like falling, getting struck by an object or against an object, and bites and stings, which can be big in Arizona. When we're caring for children in this age group in the hospital, especially, we want to make sure that we want to minimize fall risks by keeping the side rails on the beds or the cribs up. So even though these aren't babies anymore, there's still a risk that they can fall out of a bed or even a crib, especially when we have them raised up very high so that we can access them when we're taking care of them. So we want to make sure that the side rails are all the way up. We want to remind caregivers to never leave the side of the crib down if it's in the down position. So the cribs in the hospital, the whole side of it does go down so we can access it. So we want to make sure that moms and dads and other caregivers know to put that back up when they're walking away from the crib. We want to make sure that we're checking equipment and their room regularly. So we want to make sure that they're not getting wrapped up in all the wires and cords and IV lines and things that could be attached to them. We want to make sure that safety equipment is available at the bedside. So things like suction is already set up in an ambu bag. We want to make sure there isn't extra equipment around the crib or the bed that could cause some sort of danger, like a choking or a suffocation hazard. So making sure we get rid of anything extra, at least near the crib. We want to make sure that we are checking the temperature of water, food, and drinks, and also educating parents about that. Making sure that we are doing an assessment so that if there's any chance that we think there's some sort of child abuse or neglect or anything like that, that we could refer to CPS. We also want to educate caregivers on basic home safety, which we'll talk about in a moment, things like smoke and carbon monoxide detectors. Some safety measures that we can educate caregivers about for toddlers and preschoolers. Educate them to not carry hot liquids around while they're holding a child. So like a hot pot of water that's boiling for pasta or coffee. Don't allow the kids around stoves or fireplaces. If we are using the stove, try to use the back burner to minimize the risk of burns. Don't allow them around other hot appliances, things like curling irons or straighteners or toasters and things like that. You can set the temperature of your hot water heater. You want to set that to 120 degrees Fahrenheit to prevent scalds. And then, of course, checking their food to make sure it's not too hot. Still using things like safety gates at the top of stairs. We do want to secure heavy furniture to the wall. So things like bookcases and TVs, because kids can climb up on these types of things and then they can fall over on top of them. Making sure that we're keeping windows closed so that they don't fall out, especially on like a second story or in an apartment building. Not leaving them alone on porches or balconies. Using things like night lights, making sure everything's still locked up, like medications and poisons and things like that. Having numbers to poison control and the doctor nearby. Making sure that we're taking away any small toys that could present a choking hazard. So even though they may be a toddler at this time, toddlers still like to put a lot of stuff in their mouths. So we still want to look out for choking. Making sure we're not buying them toys that are for older children that may have little tiny parts, sort of like Legos. Making sure that we're securing any loose cords that are attached to anything, so especially things like blinds or curtains. Keep up to date on recalled items. We still want to be cutting food into little bite-sized pieces to minimize the risk of choking. Don't let them play with things like money or latex balloons because those are also high choking items. If there is a room that has anything that could be dangerous to a child in it, make sure that you put a lock on the door. And then supervise children around all animals, including family pets, and don't leave water and anything at all because it is a risk of drowning. So even things like a bathtub or a bucket or even a toilet, you can have a lock on the toilet. Outdoor safety measures that we can educate caregivers about. So we want to child-proof any swimming areas. So especially in Arizona, access to pools at people's houses. Also ponds and lakes, but a little less important for us in Arizona. Don't leave the kids unattended when they're swimming, even if they can swim. Use approved flotation devices. We don't ever want to leave any of their toys in the pool, and this can go along for even infants as well, because children might be tempted to retrieve them. Playgrounds and unfamiliar play areas can pose an increased risk for danger because of some of the equipment can be dangerous and they're not familiar with it. We want to make sure that we're teaching them playground and play area safety rules, like making sure that they aren't running in dangerous areas. Trampolines are a safety risk for children as well. High incidence of broken bones with those. We can start to teach them about crosswalk safety. So how to cross the road, how to look both ways, things like that. Making sure that we teach them not to run after like a ball that goes into the road. We want to make sure when they start riding bikes or scooters or anything like that, that they should be wearing helmets and other safety equipment and stay on sidewalks whenever possible. Making sure that they're using the correct child safety seat or booster seat, depending on their age, and place them in the back seat whenever possible. All of the different laws for things like car seats are different from state to state. Chapter 10 is about the growth and development of school-age children. So this is children that are ages 6 to 12 years old. Their growth does start to slow down a little bit, but they're still going to hit some important developmental milestones in this age group. So the vital signs for school-age children are listed here in this graph for you. Also, height and weight-wise, so growth-wise, they gain about 3 kilograms a year in weight and gain about 5 centimeters a year in height, depending on their actual age and if they are in puberty or not. So they are going to have growth spurts at ages 10 to 12 for girls and around age 12 for boys, which we'll talk more about in a moment. Approaches to medication administration for this age group. So medication dosing. So this applies to all age groups, but for pediatrics, we use weight-based dosing to provide an appropriate dose for kids. So children have faster metabolic rates than adults, so making sure that we're using weight-based dosing, make sure that the child is getting the adequate amount of medication. So this means we need to make sure that we are getting accurate weights. Once they reach around 14 years old or around 50 kilograms, they may start to receive a standard adult dose, but making sure that we are basing it on their weight gives us a more accurate and safe dose. So we shouldn't be basing it on age, we should be basing it on weight. For school-age children, we can let them choose how they want to take a liquid medication. So there are oral syringes, there are oral spoons, or also the little medication cups. So we can let them choose whichever they would like. We can offer something for them to chase it down with. So a certain drink, we can give them a popsicle before to help sort of numb their taste buds, have them pinch their nose while ingesting the medication, or if they do anything normally at home, as long as it's safe, we can let them do that as well. We can also let the caregiver administer oral medications. We just want to make sure that we are supervising that they do so appropriately and that the patient takes the entire dose. So there is usually a way to chart in the charting system, or at least you can make a comment that the caregiver administered the dose, but basically that you watched it. Sometimes they can flavor medications at the pharmacy, not usually in the hospital, although some are already flavored. But we want to make sure that we take caution that we don't make them taste too good so that children want to drink them. When we're giving a child an injection or an IV, sometimes we can apply some medication that may make it a little less painful. So one thing that we can apply is EMLA cream. So it is lidocaine and prilocaine cream. So it's basically a numbing cream. So we want to be able to apply this at least 45 minutes before we are going to do the injection. So it is something that's not in an emergency situation, something you have to plan ahead for. Basically, the longer that is in place, the deeper it will penetrate. So 2 hours is actually best for an IM injection, but at least 45 minutes. To apply it, you basically want to sort of glob it on the area and not rub it in. So you can cover up the cream with a dressing, like a Tegaderm dressing, so that the child doesn't mess with it. But you don't want to rub it into the skin, just glob it right on. Then once you're ready to do your injection, you can just wipe it off and then clean the area as you normally would. We also sometimes have what's called a J-tip, which is in this top picture. So this has lidocaine in it, and it basically sort of injects the lidocaine into the skin to make that area numb. We usually use this with IVs. It does make a loud popping sound, so you do need to warn the child of a loud sound that it may make. There is no needle in it. It just uses like a little CO2 cartridge to basically sort of impregnate the lidocaine into the skin. We also want to make sure that we're choosing the correct needle size and length for whatever we're doing based on how big the child is. So if we are giving an injection, an IM injection to a baby, obviously our needle length is going to be much shorter than if we are giving it to a 16-year-old. If the child does have a history of something like diabetes, where they are already experienced at doing their own subcutaneous injections, or their parents are experienced at it if they're a little bit younger, they could be able to do that in the hospital as well. This is just something that you want to make sure that you are supervising them when you do it and charting appropriately. If we are doing one of these procedures, like either an injection or an IV or whatever it may be, we can use the child life specialist to help explain what's going to happen and for them to bring distractions, so things like iPads or toys, whatever they have that can make the procedure more comfortable for the child. We also, if possible, want to avoid places that may get in the way for the child. So if the child does need to do things like color or do homework, we might not want to place the IV in their dominant hand. Of course, it isn't always possible for us to pick and choose depending on what they have available. But if we do see a good spot that isn't in their dominant hand, then we would want to choose that. Health promotion and safety information for this age group. So children that are of school age are usually very active. So they're usually doing things like riding bikes, they could be playing sports, just playing outside in general. So still, like the same with toddlers and preschoolers, unintentional injury is the leading cause of death in this age group. So we want to make sure that we are trying to prevent unintentional injuries as best we can, especially head injuries. So again, we want to make sure that they are wearing helmets and other safety equipment, and that they are wearing them correctly, and that they are doing whatever sport or activity that they're doing as correct as possible. We also want to continue emphasizing pedestrian safety, so things like looking both ways when they're crossing the street, paying attention to traffic signals and crosswalks, and walking on sidewalks if available. Children of this age, especially older children in this age group, so more like the 11 and 12-year-olds, are starting to have more independence, and they might be able to do more activities alone and do things like stay at home alone. But we don't want to leave them at home alone for any extended periods of time or overnight or anything like that. They may also be able to start babysitting, especially younger siblings. Again, not for extended periods of time, but for quick trips. Nutrition-wise, children in this age group need a decreased caloric requirement compared to younger children. So we can start teaching them about proper nutrition at this age and what healthy foods are and what other foods to eat in moderation. There is a high incidence of overweight and obese children in the United States. So about 18% are obese and another 18% are overweight. Just like with adults, this is linked with other problems like increased lipid levels, insulin levels, and blood pressure. And they have a greater chance of being overweight as an adult. So we want to make sure that they're getting at least 1 hour of physical activity a day. We want to encourage them to do things that they like to do, like playing whatever sports they like, or bike riding, and encourage participation in school sports and other programs that involve activity. Chapter 11 covers the growth and development of adolescence. So adolescence is the end of childhood and it's the transition period into adulthood. We can break down adolescence into 3 stages: early, middle, and late, which is listed there on your screen. And the outcome of this stage of development, by the end of it, the child should have advanced cognitive abilities close to that of an adult. They have become more independent and autonomous. They can do things like drive and may have a job, and are starting to form a self-identity. Listed on this slide are the vital signs for adolescents. You can see that the vital signs are basically that of an adult, so you don't really have to memorize anything here. But when we are performing an assessment on an adolescent, there are a couple of things that we need to keep in mind. So a big thing for adolescents is privacy. So we want to make sure, just as we do with adults, to make sure we're pulling the curtain, making sure the door is shut, whatever we need to do to ensure privacy. We also want to explain what we're doing to the adolescent, and we can even explain rationales. So explaining maybe why we need to put in a new IV and why the one that is in is bad, things like that. We want to focus on the positive aspects of the child and not the negative, and address the adolescent's concerns, just like we would with an adult. We also want to be cautious about pointing out any physical abnormalities. They're very easily embarrassed. So we don't want to necessarily point those out, although it may be something that we would chart. We don't need to say it directly to their face. Sort of like with an adult, we want to examine the genitals last if we even need to examine the genitals, but we want to save that for last, again, because it can be embarrassing. And we want to use the correct words for anatomy. So instead of using sort of babyfied words for things like genitals, we want to make sure we're using the actual correct word. If we need to get consent for something for a procedure or surgery, things like putting in a PICC line, we still need to get consent from their guardian. So that could be their parents, it could be their grandparents if they are the guardian. Whoever their legal guardian is will have to sign the consent form. We also, though, need to get patient consent for certain things. So just like we would ask an adult if it's okay to touch them, we also want to ask that of an adolescent. We also want to make sure that the child wants their parent or caregiver guardian present during the assessment or procedure or whatever is going on. So in some instances, it could be embarrassing for the child and they don't want their parent present, and they do have that right, so we would ask the parent to leave the room. Like I said previously, we can also explain procedures and the rationales behind them in more detail. Puberty for girls begins around age 8 and lasts to around age 13. It's completed in about 4 years. Can vary from person to person, of course. They will have a growth spurt around age 10 to 12. And for most girls, breast development starts between ages 8 to 10. We can estimate the time that they will start menstruating. It's approximately 2 years after they begin breast development. In girls, their lean body mass will decrease and their adipose tissue will increase during puberty, and they start to form things like pubic hair and armpit hair. For boys, they start puberty just a little bit later. It still lasts about 4 years, but usually between the ages of 9 and 14. They also have a growth spurt that's just a little bit later than girls, between ages 12 and 14. Opposite of girls, their lean body mass will increase and their adipose tissue will decrease. They'll also start forming things like pubic hair, armpit hair, maybe beard hair. It is common or normal to have short-term gynecomastia during this time period, and their scrotum and penis will also start to enlarge. Health promotion and education for adolescents. So education questions that we can ask basically about their school experience. So do they have any bullying? Are they frequently absent or skipping school? How are they doing in school? Like, are they failing all of their classes? And what are their feelings regarding their friends, their classmates, teachers? We can ask about drugs. So we can ask if they are using nicotine, whether that is actual cigarettes or vapes, and we can educate that vapes are not necessarily a safe alternative. We also want to see, are they using any opiates because of the increasing use of opiate painkillers. Sexuality-wise, we do need to educate that they can get pregnant after they do have their first period, and practices they can use for safe sex, like using condoms, things like that, when they should get STI testing if necessary, and different birth control options for females. Suicide and safety-wise, we want to screen teens for depression, any suicidal ideation or self-harming behaviors that they may have, so things like cutting. We also want to assess for any stressors in their life. So are their parents getting divorced? Are they being bullied in school? Anything like that that could put them at risk. We also can teach them stress management techniques and provide them resources or referrals if needed. Abuse considerations for adolescents. So adolescents are still at risk for all the different kinds of abuse that we talked about with other age groups, physical, emotional, neglect. But adolescents and young adults do have higher rates of sexual assault than any other age group. And they are less likely to report any instances of sexual assault because of guilt, or they can also be afraid that their parents won't let them do anything anymore. Boys are less likely to report sexual assault than girls, and adolescents with developmental disabilities are more likely to become victims. If the adolescent is using substances like any drugs or alcohol, it does put them at a greater risk. and there is an increasing ability to obtain certain date rape drugs, such as ketamine. Sexually abused adolescents do have increased rates of mental health problems like depression, anxiety, and post-traumatic stress disorder, so we can screen for those things. The last thing we're going to talk about for adolescents is human trafficking. So about 25% of human trafficking victims are minors, and the most common age is in the adolescent age range. The most common age is 12 to 14 years old. So certain things that you could see if someone is possibly a victim of human trafficking. They could come into the hospital or come into the ER, urgent care, whatever type of situation, seeking help for things like pregnancies, abortions, STIs, UTIs, miscarriages, mental health issues. They could come in with one of their human trafficking people that basically have them under their care. So healthcare providers can play an important role in identifying these victims and then assessing their needs and helping them.